And the key thing is it has got a soft plunger tip, which is made up of a thermoplastic material. It fills the lumen of the nozzle completely and avoids any overlight. And the main thing is that the lens is then propelled forwards by the hydraulic piston action, which is generated by the viscoelastic within the nozzle. And the conventional lens design, which we studied for this, is the hydrophilic single-piece lens with a 12mm loop span and 5.75mm of the optic. Is equibiconvex and is a single-plane design. Uniquely, it has the anti-vaulting haptic design as here, which resists the capsular contraction forces. Also, this is the first lens which provided us with a 360-degree enhanced edge to reduce the PCO. We studied 70 eyes following MICS through 1.4mm incision and then stretching the wound size to, extending the wound size to 2.2mm and then implanting the lens with this injector. We did not find any difficulty in implanting this lens through 2.2mm, and there was no damage to the lens optic or haptic that could be observed. There were no shavings from the injector. As you can see here, it's a bimanual microphacosurgery or MICS through 1.4mm. Then you extend the wound just before putting the lens in to 2.2, and you don't have to enter the anterior chamber with this injector. The tip is just docked within the wound, and then you can implant the lens quite nicely straight in the bag. But it's a two-step procedure. You have to still put the trailing haptic in the bag, which is not very difficult with this kind of design of the haptic, as you can see here. So in conclusion, this new design of the injector now offers a conventional, uncompromised design of the lens to be implanted with all its design advantages through a 2.2mm incision following MICS, which then allows you to do the surgery with all its fluidics and wound advantages. So it's a nice combination. Thank you very much.
Thank you very much. The next talk is by Dr. Amselak. He will talk about his first 100 cases of the AcrySert preloaded injector to implant the AcrySof IQ.
Thank you, Mr. Chairman. I'm going to present my results regarding the first 100 cases of injection with the AcrySert preloaded injector and the AcrySof SN60 IQ. The purpose of this study was the evaluation of the injector reliability after the first 100 cases, the identification of technical and environmental criteria for an optimized outcome. This study involved one eye of 100 consecutive patients with the SN60WF, which is a name of the intraocular lens in this injector, delivered with the AcrySof injector. The main step of the injection is the injection of viscoelastic through the injection hole inside the loading and folding chamber. Then the lens locker is removed by pulling laterally. The first haptic must be injected and folded very slowly in order to let the time to the lens to fold properly. The injection itself doesn't have any particularity. The following endpoints were recorded: the OR temperature, surgery time, US time, average power, injection time, the status of the optics and haptics, the incision architecture, incision size before and after injection. Has been measured with calipers. The collected data was reviewed to determine parameters that resulted in optimized outcome. The mean power was 22.08 diopter. The mean surgical time was 9.21 minutes, plus or minus 2.2. The OR temperature, which is of major importance for the safety of the injection, was 20.7 degrees Celsius, plus or minus 0.1, which is very stable. We used the HP2 knife of 3.2 millimeters size for the big cartridge, and the measured stretch was only 0.09 millimeter measured with the calipers. For this injector, the success factor includes the use of the injector at the OR temperature that must be included between 18 to 23 degrees, and the using of smooth and slow pressure. The injection time was 26.56 seconds, and you can see on the graph that there is a decrease in the injection time with the experience. We observed no cracks, no damage on the optic and the haptics. The haptic adhesion, we had 2 cases among the 10 first cases, and the adhesion was removed during the IA phase with a second instrument. All incisions architectures were preserved after implantation with excellent self-sealing closure at the end of the case, but also at D1. For conclusion, the reproducibility and ergonomics of the AcrySert injector were excellent during the study. Using the described technical and environmental recommendation, especially the OR temperature and storage, allowed the insertion of a pristine intraocular lens with a reduced time of implantation and surgery. AcrySert allows the injection of the SN60 WF lens without any handling of this lens for a safer procedure. Thank you very much.